see me, but it's kind of dark, so I can't read what I wrote. And he's considered a data scientist of his... No, I got the wrong guy again. How about if I introduce Peter and let him tell you who he is and what he does? Let's go for that, okay?
All right.
So good afternoon. Thank you all for deciding to continue this trek down risk adjustment. Again, my name is Peter Winston. I'm Executive Vice President for CINRMED. We're an MSO. You know, healthcare is all about acronyms, Management Services Organization. So as you're working through your PPGs, your provider groups, your IPAs, your independent physician associations, we're the guys who run the back office for all of those delegated risk takers that you're assigning those contracts to for all the lines of business, whether it's Medi-Cal, Medicare, commercial. A lot of what we've been talking about today has been on the Medicare side, but what we're going to talk a little bit more is how, from the doctor's perspective, how risk adjustment and the different lines of business are basically intersecting, which is part of what we learned about this morning with John's talk. Our footprint at CINRMED, just a real brief, we have about 700,000 lives. We're not an HMO, but we're responsible for 700,000 beneficiaries throughout the state of California. We cover all of the product lines, Medicare, commercial, Medi-Cal, soon to be the exchange. We also have some other sidelines of business that we work on as well. While the focus is keeping providers prepared in the loop, there's a lot more going on than just risk adjustment. In fact, risk adjustment means different things to different people. Remember, we've been focusing predominantly on seniors, HCC scores, how we're going to get that information to CMS, what that means in terms of our revenue. But it's more than that. It's about P for P. It's about Medicaid RX. We'll talk about both of those. And with the Affordable Care Act, providers are basically freaking out and otherwise not listening to anything that you're saying to them right now, because of everything that's coming at them from every separate direction. So let's talk about one of the things that's happening as a result of the Affordable Care Act, the expansion of Medi-Cal. We heard a lot about that this morning, what's going on with the exchange. Actually, the first set of numbers have actually come out from the exchange. I'll talk about how that impacts Medi-Cal. Right now, what we know is we think there's going to be about 8 million new Medicaid beneficiaries nationwide. California, somewhere between 1 and 2 million as a result of the Affordable Care Act. So, first fallacy we need to debunk. These are all new patients. It's not like we just opened the border to Mexico and they all just came streaming out and they're all running directly to your doctor's offices. That's not what's happening here. These are patients who are already getting care. They're already seeing the doctors. They're already here. They are not new. If you want to talk about risk adjustment, let's talk about where care is delivered, because that's how patients may be required to switch physicians, to switch IPAs, and potentially to switch health plans. But as I like to quote Yogi Berra, it's deja vu all over again. How many times have we heard that the sky is falling every time a new program is introduced? Let's just look, brief history. In the mid-1990s, we moved over 2 million TANF members from fee-for-service to managed care, and the sky didn't fall. We survived. Then we went to the SPDs. This is classic risk adjustment, except of a different nature. The risk adjustment here was saying, instead of having an open checkbook of unmanaged care, we're going to go ahead and fix the premiums by putting them into a managed care plan and let you guys, the health plans and the delegated provider groups, figure out how to deal with it for the dollars that we're going to give you. If traditional insurance is healthy subsidizing the sick, the challenge with this population was that they were all sick, and I had no healthy patients to subsidize with. So how are you going to address the needs of this population? Jane Ogle likes to tell a story when we talk about the transition of the SPDs and how some folks were really against the transition because patients were losing access to their physician. And so one patient came up to Jane and made that statement, and Jane said, "And tell me, how many physicians do you have as your primary care physician?" And she said 17. And so the whole reason for moving into a managed care system is to provide more accountability, because under the old system, everybody was in it for themselves and nobody was truly coordinating care and championing for the patient. If the patient is supposed to be at the center of all things, then unmanaged care is doing everything but. We talked about S-CHIP, otherwise known as Healthy Families here, and moving them into the system. Here's one I'm wary about for a different reason. I have no problem moving from a commercial plan into a Medicaid plan. These are low-income children. Great. They now have benefits they actually didn't have. VFC, the Vaccines for Children program in Medi-Cal, free vaccines from a doctor's office to give to kids, because under the Healthy Families program, the doctor actually had to pay for it themselves. So we're actually saving money to the system that we can invest elsewhere. Of course, what the state then did is lowered the premiums paid to the health plans for this cohort of patients. So you're getting less money, I'm getting less money. If I put my crystal ball on, I would keep an eye on your TANF populations, because as redetermination comes around, take a bunch of these low-income children, take them out of TANF, put them into the child category, and you'll see a 40% reduction in that revenue. If you're a pediatrician, lower rates are coming. If you're a fan of Game of Thrones, it's called Winter is Coming. We talked a little bit about rural expansion. In every single case, the risk adjustment is coming at the state level, moving from an uncoordinated, unmanaged, open checkbook system to managed care, the stuff that everybody in this room lives and breathes on a daily basis. By the way, has anybody figured out that California Health and Wellness is the new CHW? Right? See, Catholic Healthcare West became Dignity. It left the gap. So Centene, California Health and Wellness, took on the acronym. So CHW still remains in California. This is where the fun is. Everybody says this is where the money is. This is also where all the heavy lifting is going to come from. As it stands, the mandatory conversion of these many patients is scheduled to begin in April of 2014. But here we have a different risk adjustment problem. While Medi-Cal managed care will be mandatory, Medicare managed care is not. They don't have to necessarily join an MA plan. They may be passively enrolled, but they don't necessarily need to stay there. So this will create a churning problem where multiple specialists will be telling their patients to opt out after they've been defaulted in, so as to not lose access to these patients. It's all about turf. Personally, I think this cohort will be more of a challenge to integrate than ACA expansions, especially with the need for all of the additional services that this population will require. We talked a little bit this morning about long-term support services and all those other services. And in traditional risk adjustment, such as chart reviews and HCC scoring, they'll absolutely play a role here as long as the patient stays in an MA plan or a D-SNP plan. But if they're going to churn in and out, your risk scores are going to be for shit. Turning back to ACA expansion and the provider perspective, one of the things we look at is whose eyes are we looking through? So one of the eyes I want to look through is that of the nonprofit. The challenge for federally qualified health clinics, FQHCs, community clinics, rural health clinics, and other nonprofits is their fear of losing patients. Think about it. In the past, these patients had no choice. If you didn't have insurance, you went to two places. You went to the ER, or you went to a nonprofit. Maybe it was free care, maybe it was sliding scale, but those were really the only two places you got to go. You really didn't have a choice. The question for the nonprofits is, how do you live on a $28 Medicaid office visit fee when your rate is $150, your PPS rate is $150? That's where the freak out is. But the fact is, the nonprofits have had several years to plan for this. They've had access to grant funding that others have not. They've implemented electronic health records. They've become NCQA certified patient-centered medical homes. They've even spruced up their clinics with a new coat of paint. But the question remains, what will an uninsured patient do when they get an insurance card, even if it's expanded Medicaid? Before there was no choice, now there is. And now they must compete with the private sector, who, by the way, is already responsible for 70% of the Medicaid spend. So it's a doctor on the corner that's seeing most of the patients, not necessarily the FQs. Crossing your fingers is not an option. For Medicaid expansion, the answer is simple. Embrace it. Over the last 15 years, Medi-Cal IPAs and provider groups have expanded. We were always relegated to the back room of the conferences. Nobody liked us. You know, I was spitting in the wind for years. Bill can attest to that. All of a sudden, commercial membership started going down, profit margins started getting tight, and I became the prettiest girl at the dance. It didn't matter what I wore, what kind of makeup I had on, everybody wanted to talk to me. And that's what's happening. These patients are coming into the system, they're coming in through government portals, and they're coming into my networks. So as the health plan side, what are you doing to embrace those groups to build on the successes that they've already done? Looking at it from another perspective, it's strictly a payment transition from uncoordinated to coordinated. And as far as risk is concerned, we anticipate that pathology will be greater than TANF, but less than the SPDs. With Medi-Cal such a big piece of the ACA puzzle, let me at least recognize two health plans that have tried to address this head-on even before ACA, and that is LA Care and Inland Empire Health Plan. Both of those have said a $100 premium for a TANF patient does nothing for risk adjustment. You were paying the same amount of money for a 5-year-old healthy child as you were a 55-year-old diabetic with congestive heart failure. There was no risk adjustment. They at least took that and said, let's go ahead and at least age sex band things. So we at least will pay a little less for the peds, a little more for the adults, and we don't have this cherry picking of, I'm only going to have pediatricians in my network because that's where I make the most money. If you want more IPAs to contract with physicians that see adult patients, then you need to adequately compensate the downstream delegated groups for it. Both of these plans have done so. The challenge is for every other plan to recognize that and do it as well. But there are other factors on the horizon, some that have been discussed today, some that have not been discussed today. Number one, the updated fee schedule, the Obama bump. How is that going to come down? Is the health plan going to pay the doctors directly? Are they going to pay the IPAs and let the IPAs talk to the physician, pay the physicians? How are we going to do this? Does everybody here in the room know that there's a new CMS 1500 form? And that it could be used starting January 1? And are your computer systems ready to take those forms in so you can process a claim without screwing it up on the first day? And then you have ICD-10 coming down the pipe. Everything on HCCs was ICD-9, guys. I heard nothing on ICD-10. Oh, that's just too far away to even think about it. What's ICD-10 going to do to your risk scores? Have you done your crosswalks? And meaningful use. And then, the big elephant in the room, Covered California. Leaving aside for the moment the trials and tribulations of getting websites to work, Covered California remains the big unknown. They play a role in getting insurance coverage for folks. They also play a role in expanding Medicaid coverage. People are going to go into the website. They're going to figure out what they're eligible for, and a certain percentage of them are going to find out that they qualify for 100% subsidies, called Medi-Cal. And in fact, yesterday, or the day before, Covered California came out with their first numbers. 370,000 applications were submitted. 86,000 qualify for actual insurance policies. 72,000 qualify for Medi-Cal. That's almost a 1-to-1. For every 2 people going onto the exchange, half of them are qualified for expanded Medicaid coverage. So think about where your patients are coming from. Financial models will include PPO and HMO, but look closer. Where's Aetna, Cigna, and United? It would appear the exchange is trying to build a commercial product on a Medicaid platform. But if you want to talk risk, then ask why these larger players are not in the game. These patients are uninsured. And we heard earlier today from John Gorman that if you wanted to throw them in a RAF profile, they'd be between 1.4 and 1.6. So they're uninsured for either because they have a high deductible plan or they're uninsured because they're sick as hell. Call it a shift from experience writing to community writing. I mean, you think about it, if I had a high deductible health plan and I was still paying $1,000 a month, and I can now buy a plan for $300 a month, you don't think I'm going to jettison that old plan? Sure. But moving to community underwriting does not mean that underwriting and risk does not occur. As stated by pundits, if not enough young invincibles sign up, even community ratings will show its underside. And even if you liked your health policy, they've been canceling it, and if anybody's been on their little news feeds today, President Obama did say that everybody can now keep their coverage for 1 more year. So they've delayed the implementation. And they've told every health plan, you've got to now rescind your cancellations. Okay, again, all of you health plans in the room, what's that going to do to your computer systems? That you now have to reactivate how many policies in your individual markets. The risk adjustment has shifted from the government to you, because you now have the risk of trying now to satisfy this demand for service. Small employers have new risks and new choices. Do they go on the exchange? Do they stay out of the exchange? One of the big issues in the small business exchange is the role of brokers. Okay, there's a risk there. I mean, you talk about total disruption of a marketplace. They don't know what their role is going to look like. From the provider community, the impact is based on a doctor's contracts. For PPO business, it'll fall directly to your PPO contracts. For the HMOs, it's based on your IPA affiliation. Some health plans have developed their own narrow networks of FQHCs. Is that going to get the biggest bang for the buck? Maybe, maybe not. We saw news reports about some of the teaching hospitals that was mentioned earlier in one of our discussions, that they're being excluded from these narrow networks because of their costs. In Seattle, we saw Children's Hospital sue Molina because they were left out of the narrow network. I believe that case is now settled, and Children's Hospital of Seattle is now in the network. I've not seen the same thing with Cedars-Sinai or with UCLA. So while these clinics, who are afraid of losing uninsured patients, may not have access to an Anthem or a Sharp, they will have access to an LA Care or a Molina. So nonprofit clinics could lose patients with expanded Medi-Cal, but gain patients through the exchange. Again, how these balls are being juggled in the air, how they're going to settle down, we don't know yet. Being on the provider side of the equation, how do we help our physician community partners? You focus on what we focus on all the time. You focus on collaboration. Oh wait, this is a conference on collaboration, right? You focus on exchanging information. There may still be silos, but the goal is to connect them with bridges, and technology is the key, even if you have to drag them kicking and screaming into the 21st century. We're talking doctors. You guys are investing in the technology. Doctors are cheap. They won't spend the money unless you make the case for them to do so. In some cases, we've bought EMR systems for their office. It's all about engagement. Which brings us back to the question of general risk adjustment. Let's talk about boots on the ground. It's not about paying $150 for some annual health assessment, and what you get back is a 15-minute office visit claim form and saying, and then they ask, where's my $150? Nor is it the pseudo process of compensating by aid code, like the state of California does currently. Although they have introduced risk adjustment based on the Medicaid RX formula. So HCC scores don't matter. It's the physician's prescribing habits, which means all that off-label marketing that the pharma reps have been doing, that's what's going to affect the risk scores on the Medicaid patients. And Covered California, which we'll learn in just a minute, has their own risk corridors that will be taken into account. Plans and provider groups are hiring certified coders to scrub records, but there aren't enough coders to go around. Companies like ClearVision, we heard earlier, have smart tools to find gaps in claims. But the big news is really the adoption of electronic health records. Because some of these EHRs do an insanely good job of capturing data, even the minutest of data, whether the provider knows it or not. They have crosswalked, we talked about Category 2 codes, they have crosswalked every Category 2 code out there and every CPT code. What's happening is the billings that are going out are resulting in 50 to 100% increased revenue to these clinics. Everybody's looking at it and saying, fraud. No, least common denominator. When you have 15 minutes to see a patient, I don't have time to click off 30 separate codes for documentation purposes. I got to get to the next patient. But these systems have the smart logic built in. So as I'm clicking, blood pressure, I got 2 Category 2 codes. And by the way, I heard we talked earlier about the BMI and when to use it, when not to use it. You know when to use it? All the time. If you do anything conditionally with a physician, they're not going to do it. It requires them to think. Okay? You want to get the data all the time. You scrub it. Just give it to me. If I get the data, I can do something with the data. If I don't get the data, I'm SOL. I want the data. I want every blood pressure, systolic and diastolic. I want every BMI. I want everything that is possible that you can get from data. I'll figure out what to do with it. And just wait until the other HIE comes in, the health information exchanges, not the insurance exchanges. Now when you start getting information from the ER and from other doctors and pharmacy data, it starts all coming into your system that you have access to. Now we're talking about not data, we're talking about information. And you want to put it all together. It's about engagement. It's about bringing all the stakeholders together into one place. It's about all points of contact, whether it's the health plans, the provider groups, individual members, and the physicians. There's a big push on creating new integrated delivery systems. I think it's just everybody wants to look like Kaiser. Look around you. Optum, Memorial Care, Providence in Southern California. You can't buy a doctor, but you got the foundation models, you got other things that are happening. The relationships that you have with your physicians today are not going to be the relationships you have with your physicians tomorrow. We are on the cusp of a major realignment and consolidation here in California. What's a provider to do? Well, we're not just going to sit back and wait for shit to happen. The goal is to get information out as often as possible. We will create individualized websites just to get out information. These are just a couple of them. It's really not something to promote myself, but it's stuff that we do. We push out information, CaliforniaMedicalChanges.com. It's a little blog on what's going on, the rurals, the duals, things like that. And then we'll have specialized services. Who in California is doing a hot spotting survey? Taking the 5%? No. How about the 1%? Who is investing in creating a clinic for that 1%? That patient who probably takes up 40% of your entire premium dollar, that one patient. Who's taking care of them? If all you're doing is delegating that to an IPA and then sort of clapping your hands and saying, thanks, problem's all yours. We're doing the patients and we're doing ourselves and we're doing the system a disservice. We're partners in this. The health plans, the physicians, we're partners. We talk about other kinds of disruption. Sacramento, right? Anybody have a problem trying to negotiate a hospital contract in Sacramento? How about opening a birthing center? Birthing centers are not available to Medi-Cal beneficiaries. So we did one. It'll cost half of what a hospital will cost. Maybe we can even reduce C-section rates. Oh, can somebody spell HEDIS? I'm sorry. These are the things that we all need to think about, outside the box, what's going on in your environments, and then engaging different people, different players. All of that is the true risk adjustment. So if you want to talk about it, let's look at what's happening around you. Implementing the Affordable Care Act is like recognizing there's been a major quake in the middle of the ocean that happened back in 2010 when the law got passed. And right now that tsunami is heading in our direction. The risk assessment, as opposed to the risk adjustment, is whether you see this giant wave as a threat and about to outrun you, or an opportunity that you take advantage of. So on that, I say, cowabunga.
All right.